So I'll start with the shoulder since we were there already. I have told you I don't call it frozen shoulder, I call it stiff shoulder. So this is commonly दिखता है लोगों के you find in your family, in your neighborhood, हाथ ऊपर नहीं उठता, you are disabled, night pains, and it lingers on for many months, especially in diabetic person, it's very common. So majority of these patients can be managed medically. You don't require to do any kind of surgery or anything of this, but in some cases, yes. This is a girl who came to me from Kashmir. She was having a secondary stiff shoulder following she was a rheumatoid patient, and under anesthesia I examined her. This was the restriction under anesthesia because she will not have any pain. So if the restriction of movement was there because of pain, even that we have eliminated. So there was an objective evidence of taking the patient for surgery. So we did do arthroscopic surgery. Arthroscopy is keyhole surgery. We don't cut open the joints. So we don't do any collateral damage when we are approaching the diseased area. So, and I make them move the parts within 4 to 5 hours of my surgery, because that's the time I am free after the surgery. I would love to start immediately after, as soon as they come out of the operation theater, but because of technical reason it's sometimes not possible. And see this, the second slide, this is the almost full range of movement she is having. Okay, this one aspect, okay, she gets full range of movement after surgery, great. But for me, what is important, once I leave her on her own, is this movement is going to be retained or not? That's more important for me. So this girl came to me 3 months down the line. Now she is off the medicine, off my supervision, and she is having almost full range of the, she is having full range of the movements. So this is what we basically do, persons who are not improving, but as I said, 90% of the patient we can manage by arthroscopy. I have included this slide because I thought there are a lot of persons from engineering background, and I use a lot of engineering stuff from my from the engineers who have designed this stuff, made my life easier to do surgery. So these are some of the keyhole instruments which I use for surgery day in and day out. These are the cannulas which basically keep my track open when I am doing surgery, so I don't lose the track. These are the 4 millimeter arthroscope. There is a telescope. This thing, it's a rod lens through which basically we see the live portion of the inside the joint, and to the outer aspect of it. Can you see the cursor? Do we have a pointer or something? Okay. Outside the this thing lens, there is a camera fitted through which I see the live this thing. So there is I am also seeing the surgery directly on the monitor. I think majority of us are now aware what is the meaning of keyhole surgery or laparoscopy or arthroscopy surgery. So now different kind of besides stiff shoulder, I do approximately 70% of my surgery involves now keyhole surgery, wherever I have to operate. And my rate of operation, if I see 10 patients, usually only 1 or 0.5 patients will be requiring surgery. So this is like, if you can say, get the rough idea, how much patient do require surgery. And I get patients, not just pain, this kind of thing, patients who are referred from other orthopedic surgeons also. Still, my percentage of patients requiring surgery is less. And out of this also, basically, I can manage majority, 70% of the patient by keyhole surgery. So keyhole surgery involves different kind of setup. You need very precision because your visibility is in the 4 millimeter and you have to see the whole of the joint. It's few things which we cannot do open, we can do arthroscopy. Reason is, I can, with the arthroscope, I can go in front, I can go in the back, I can go inside, outside, laterally, medially. I hope you understand lateral medial basically in terms of anatomical part. Laterally is outside and medially is towards the inner aspect. So whereas if you do the open surgery, you can't achieve because you are gonna encounter vital structures like blood vessels, nerves. Unless you damage them, you can't reach. So these are the different kind of anchors we do have. These are metallic. There are biodegradable implants are there. They are knotted, non-knotted, and so many now vast engineering help is there with us to make my life more easy. So we use this technology to basically produce the fixation of the implants. Still, I think in coming time, the BIS I think should help. We do have very less number of Indian good quality implants. Majority of these implants are imported. These are hardly 5 but each 5 costs more than 15-20,000. So I think with Modi ji initiative and BIS initiative, maybe in future we will have easy access to the good Indian implants. So like shoulder, we do for stiff shoulder, for wherever the shoulder is coming out, that is we call instability surgery, or there is a sort of a paralysis of the shoulder, person is not able to move his or her shoulder, or pseudo paralysis, or there are so many other lesions like commonly we get a lot of sports person, cricketers, throwers, and even routine person who are not involved in the sports but have to travel in the metro or this thing, jug comes, so many other, you are basically doing some work, you are off your this thing, suddenly you want to get back into that, and as is that the injury occurs. So we do a lot of this thing in the shoulder. I do a lot of shoulder replacement also, partial shoulder replacement, total shoulder replacement, and reverse shoulder replacement. Reverse shoulder replacement is again we use engineering, more of physics than, it's a combination of physics and biology, where the muscles are not functioning properly. So what we do, we change the biomechanics of the shoulder. Center of rotation of the shoulder is here. So what I do, there's only one muscle which is functioning. So in order to increase the effectiveness of that muscle, I bring my center of rotation of the shoulder a bit more outside. So the deltoid actually is the only functioning muscle left when we do this. So as a result, this muscle become more, its functional capacity improves, and we are able to achieve what we would not have been able to achieve just by biology. We use the principles of physics and biology combined. I'll show you what I meant. Like this is, I'm sorry, I don't have a cursor. The first I have to see, in case you are not able to understand, please do let me know. The first slide, first picture is basically partial shoulder replacement, where we just, the humerus bone, we just replace that part. The other picture is of total shoulder replacement, where we replacing the cup as well as the ball. And the third one is basically what I was telling you about the reverse shoulder. See, this is the nature way, ball is outside, cup is inside. We change it. Where the ball is there, we are producing the cup. Where the cup is there, we are producing the ball. So we are just simply changing the biomechanics. A lot of orthopedic surgery is basically simple marriage between the biomechanics and the biology. So I'll come to the knee straight way. I think everybody, सबको यहाँ आधे से ज़्यादा लोगों को घुटने का दर्द तो जरूर होएगा. And it's there at various stages, whether you are young, old, active, you will get knee pains somewhere or other down the line. So it will trouble you. So different kind, again in knee also I do lot of surgeries, 70% by arthroscopy, where surgery is required. Please don't get the idea when I mention surgery that every patient requires surgery. Okay. So again, these are the kind of meniscus repair or washer. I have used a lot of animation to this thing. In this, basically what we do, again, these are all arthroscopic techniques where we do keyhole repair of the meniscus. Whatever I do, it's not my own brain, this thing. It is we work on the established international guidelines. So even sometimes some procedures may look sort of unheard of, but still there is a solid background to it. Then only we undertake the procedure. We can't just take any procedure just like that. So these are the guidelines by which we follow. Life condition is improved. She is smiling. She is having good range of the knee movement. So that's what basically. Sometimes you get other collateral benefits also. We do even now in the area where we are getting a lot of revision knee replacement patients also. I use computer navigation also for knee replacement. Basically it helps me to where my naked eye can't see 1 degree of angle, 1 millimeter of angle distance. But with computer navigation we are able to improve upon 1 millimeter or even 1 degree. How much this actually results in benefit, functional benefit is still not very convincing at present. In some patients, yes, not in all patients.